Now it's time to move on to AML and Dr. Sasha Pearl. Again, thank you for being here today.
Oh, my pleasure, John.
And you know, I look at AML as a lymphoma doctor, but certainly occasionally hearing about AML patients, there seems to be a lot happening. But I also see in some of the studies we're going to talk about 7 and 3 hasn't gone away. And people are still working on making it better. So we'll get into the details of this. But first, a few new agents that I think it seems like people need to know about, and I keep hearing about the concept of the IDH inhibitor, IDH1 inhibitor, and how we take that forward. This is a drug, ivosidenib, if I'm saying it correctly.
Ivosidenib, yeah.
Ivosidenib, thank you. And the net is that this is really, it seems like a very important and exciting new agent.
And it falls right on the heels of enasidenib, which is the drug from the same company targeting IDH2. There's 2 different IDH mutations in AML, IDH1 and IDH2, that create the same function, but you need different drugs to inhibit the enzyme itself. Enasidenib is the IDH2 inhibitor, and that's actually FDA approved already. Ivosidenib is targeting IDH1. And I have to say, if you look at these two in separate studies, but very similar patients, they look so similar, it's almost impossible to tell them apart. This, like enasidenib, is a drug that they were able to dose escalate from very low doses to very high doses, here from 100 milligrams all the way up to 1,200 milligrams, found no obvious dose-limiting toxicities along the way, and picked a kind of medium dose to move forward because they had a biomarker to say they were inhibiting the target of the drug and reducing this byproduct of IDH mutation called 2HG. And they did that with very low doses of the drug. They do not see an obvious drug-associated toxicity profile at this dose, but they do see differentiation syndrome with this drug, as they did see with enasidenib. It doesn't happen in a lot of patients. Here they saw it in only 11% of patients, but it still does happen. You still do need to look for it. And like APL differentiation syndrome, patients can get quite sick from this. You need to recognize it, manage it to prevent that complication. But it looks very promising, and I know that this drug is poised to be submitted very soon to the FDA for review based on these data. So this is very exciting.
So our group has been involved in the studies. I know the Memorial Group clearly has also been very involved in this category of drugs. I've heard about some pretty impressive responses. I've also heard of some that were relatively short-lived. So it sounds like there's more work to do. Where do you think this is going?
I think one of the exciting and interesting things about AML, and one of the hard things about it, is that it's a really heterogeneous disease. And one mutation means you have a target, but it doesn't mean that if you use the same drug, it will always get you the same response. And that's because these mutations fall in a background of multiple mutations. And I think it's really that combination which opens up the door for, can we target more than one mutation with more than one drug? And I think that's the next thing that we're going to do in the field.
Great. Okay. So the next study is by Wei and colleagues that we wanted to touch on, and this is a study that took patients, older patients with AML, and uses as a backbone the lower dose Ara-C approach that people, I think, have been using for a while, but now adding in venetoclax, the BCL2 inhibitor, to this approach. And I think the data were fairly interesting. What are your thoughts on this trial?
So there are actually a few studies of venetoclax added to low-intensity chemotherapy. This one looks at low-dose Ara-C, and last year there were presentations of venetoclax with hypomethylating agents, and the data, again, are very similar. It looks like the addition of venetoclax to that background of low-intensity chemotherapy dramatically increases the response rate. And what's interesting about this abstract is not really the response rate, which you can do by adding more agents to low-dose Ara-C, but the durability of the responses, which I think is much more important. There have been many drugs added to low-dose Ara-C that have had better response rates, but no improvement in survival. We can think of clofarabine, we can think of volasertib, we can think of gemtuzumab oxazomicin, and none of those drugs won out in phase 3 comparisons. This looks very promising because the one-year survivals actually look very, very good. The median survival in this study is about 11 months. I believe 46% of patients were alive at a year, and those numbers look about twice as good as what you'd expect for low-dose Ara-C alone.
So where do you think this is going to fit in relative to the hypomethylating agents, which seem to also be used in this group of patients?
I think the hard thing is, many of these patients who get to AML have already seen a hypomethylating agent for their MDS and then develop AML. What's notable here is a significant proportion of these patients that had prior hypomethylating agents and still responded, which which is hard to do with 7 and 3. So that's actually quite interesting. And some people have even posed the question of, should we be testing regimens like this against a comparator arm of 7 and 3 rather than a comparative arm of low-dose Ara-C, which I'm not sure we're quite ready for, but I think that is potentially a question we could move towards.
Great. Okay.